Hi, everyone. On behalf of GU Oncology Now, I'm Brian Rini. I'm the Chief of Clinical Trials at Vanderbilt University. I'm pleased to be joined today by an expert panel of kidney cancer experts, and we're going to talk about really the spectrum of therapy for frontline kidney cancer, from observation and drugs, and also some of the new data, including triplets and what will be coming out in the next year. So I'm going to have each panel member introduce themselves, and we'll start with you, Dr. Ornstein.
Hi, I'm Dr. Moshe Ornstein. I'm a GU medical oncologist at the Cleveland Clinic, where I spearhead the RCC efforts.
Hi, I'm Shuchi Gulati. I'm an assistant professor at UC Davis Comprehensive Cancer Center. I'm really excited to be here.
Monty Pal. I run the kidney cancer program at City of Hope in Los Angeles.
Great, thanks all for being here. So let's spend the bulk of our time talking about doublets. Where to start? Well, we'll take it in order. So Ipi/Nivo is the first data to come out. Let's talk about that first. Who's using it? Shuchi, you can start. Who are you giving it to? How are you selecting? How much are you using? Maybe we can start when people start talking. Say what percent of patients get Ipi/Nivo?
In my practice, I'd say, part of it depends on whether I'm considering patients for clinical trials, because I said,
let's take clinical trials off the table. Yes.
So in my practice, I would say I tend to use Ipi/Nivo in definitely intermediate poor risk patients, and in patients if I'm concerned about them having too many side effects. Like I saw a patient who had recently had a hemorrhagic stroke related to very high blood pressure, so I'm going to steer away from a TKI and I'll go with the Ipi/Nivo. But my practice predominant is an IO TKI practice, but I will definitely consider Ipi/Nivo for patients if I can't use a TKI or if they are intermediate poor risk disease patients.
Okay.
Yeah, I would say probably 15 to 20% of my patients get Ipi/Nivo. For sure, if they have sarcomatoid features, then I go with Ipi/Nivo. And I'm trying to develop, I think we all think that we can select patients by seeing them in clinic and looking at their scans and looking at their labs at who's more likely to respond to one thing versus another. I tend to find that the patients most appropriate for Ipi/Nivo, where I think they can really have a durable response and then be on Nivo once a month, are patients with lung and lymph node disease only. I find that for patients, if they have liver mets or they have bone mets or they have brain mets, it's IO TKI. But I will give Ipi/Nivo for patients with that couple pulmonary nodules, some mediastinal lymph nodes or retroperitoneal lymph nodes.
Is it because they don't need the upfront response?
Exactly.
Or you think that actually they have some biology that's more responsive?
So certainly because I don't think they need a response right now and they're more salvageable in a later line. So that's first and foremost. And then also I think there is something about sites of disease dictating biology. And there's something about those patients that feel like they act a little differently.
Have you ever seen data like from Checkmate about the responders and do they fit?
So I have asked about it, but I haven't seen the data.
Yeah, to your point, I don't disagree. And I'm sure there's different biologies for different organ sites. I don't know that we know a lot about it, but chest disease, in fact, back in the day in Cleveland, we looked at like sites of disease and bulk of disease, and definitely disease above the diaphragm was more indolent. Right, so it's lymph nodes, lung nodules, whereas when you get liver and other stuff, they tend to be more aggressive. But
it's interesting because when you think about it biologically, right, those patients might cluster in sort of a good risk category. And again, it's hard to estimate these things. Yeah. And we've always thought of good risk disease being perhaps a little bit more angiogenically driven. I don't think that's well established, but I can see both sides of the argument for using TKI in that context versus IO.
Yeah. What's your practice? Are you giving any Ipi/Nivo?
I certainly am in that setting that I outlined earlier. So for that patient where I'm 100% sure they're headed towards cytoreductive nephrectomy, right? Okay. I'll actually go ahead and start on Ipi/Nivo. Otherwise, for the most part, based on response rate, other criteria that I'm sure we'll go over in the next portion of this debate, I tend to stick with TKI/IO up front.
Okay. Sarcomatoid you're giving?
Sarcomatoid, I'll still give consideration to TKI/IO. I think that, Ipi/Nivo is totally reasonable in that context. But, if they have symptomatic aggressive disease, which many of my sarcomatoids do, I'm still looking to use a TKI there.
Do you believe, so the Ipi/Nivo believers, my practice is similar. It might be 1 or 2 out of 10 patients, sort of the young, lower volume, healthier. Do they pass the eyeball test of can they tolerate Ipi, which many to most don't, but and or sarcomatoid. if I were an Ipi-Nivo defender, I'd say, well, the tail of the curve's higher with Ipi-Nivo. Right? Let's start with you. Do you believe that?
I love this, sort of Twitter dialogue that, your buddy Tom and
You love all Twitter dialogue.
I do
Let's
love
start
all
there.
Twitter dialogue, but that's a long conversation. I don't think we can fit that in 45 minutes. But when Tom put out that statement around the Ipi-Nivo curves, it really got me thinking, because there's so much instability, I think, as he calls it, on the tail end of that curve, right? We always look at that 5-year update and say, look, there's 31% of patients who are progression-free. But you look at the actual number of patients at risk, right? In the bottom there, it's 10% of the original study population. So I think we probably need to dig a little bit deeper before saying, hey guys, look, there's a real tail here. We just don't know that necessarily.
Yeah, what do you think?
Yeah, and I would add, I would probably want to look at the tails for all the other trials, look at long-term follow-up data for all the trials before we can make 100% comment on, oh, this is like, long-term.
And we're just, Axi-Pembo just now has a 5-year minimum that'll be presented at an upcoming meeting near you. So we'll start to see those IO-TKI tails, which we haven't had them yet. We don't know if there is a tail, we just haven't seen the long-term data.
Exactly.
What do you think?
Yeah, I mean, in any of these trials, when you get to that 4, 5, 6-year follow-up, you're going to have a ton of censoring, and you're going to have much fewer patients if you go back down and look at the fine print. But I think there's something about the tail of the curve with the CTLA-4 that we have to wait and see the other trials if they can match up to it. I think ultimately what the question is, even if there is some marginal benefit at the very end, taking into consideration the censoring, is that small benefit for really a few patients, does that override the upfront benefit of higher response rates, higher CR rates, longer PFS? So that's the balance.
That's what you're trading off.
Right.
Yeah, no, I agree.